For an individual suffering from severe hyperacusis, everyday sound triggers an immediate, painful physiological reaction. The acoustic environment is experienced as an acute physical assault. This chart maps the normal boundaries of human hearing. For a typical individual, comfortable sound intensities range between 35 and 90 decibels. The threshold where sound becomes painful, the uncomfortable loudness level, or ULL, occurs at around 100 decibels. In severe hyperacusis, that threshold collapses. The uncomfortable loudness level crashes to 50 decibels. The comfortable hearing zone is compressed into a tiny sliver, making normal conversational speech overwhelming. Traditional audiological assessments are designed to identify mechanical failures in the ear by measuring the lowest volume a patient can detect. This focus on hearing loss often overlooks abnormal intolerance to moderate volume. This condition is distinct from loudness recruitment. Recruitment is an abnormal relationship between intensity and perceived loudness caused by noise-induced hearing loss, where the threshold of hearing is elevated. Hyperacusis routinely occurs in patients with no measurable hearing loss. Hyperacusis is not a failure of the mechanical structures of the ear. It is a complex discomfort of loudness driven by neurological and psychological factors that standard hearing protection cannot resolve. Audiologist Dr. Danesh developed a clinical framework based on the idea that treating hyperacusis requires a synchronized multidisciplinary approach. This model is built on 3 pillars: sensation, emotion, and cognition, collectively known as the SEC model. The clinical presentations of the disorder, loudness, annoyance, fear, and pain, distribute across these overlapping sectors. This framework suggests that addressing auditory sensation alone leaves the emotional and cognitive drivers of the disorder untouched. Clinicians must simultaneously target the emotional limbic response and cognitive behavioral loops. The sensation pillar is governed by the central Dane paradox. When the brain detects reduced neural input from the cochlea, it compensates by amplifying sound-evoked activity. It effectively overcranks its master volume. Prescribing earplugs actively worsens this. Starving the brain of acoustic input forces central gain higher, making the patient even more sensitive. This process generates a distinct physiological reality known as noxacusis. Noxacusis is characterized by extreme sensitivity to sound that results in physical pain. Research identifies 2 initial mechanisms for this pain. In the middle ear, nociceptive signaling is mediated by the trigeminal nerve. In the inner ear, type 2 nerve fibers transduce nociceptive signals. A third mechanism involves maladaptive hyperactivity within the central auditory brainstem, mediating persistent pain. Clinical intervention for the sensation pillar relies on acoustic environment enrichment. Patients use sound therapy, such as continuous low-level broadband noise, to gently desensitize the auditory pathway. Retraining the auditory gain and pain pathways through controlled acoustic exposure reverses the biological logic of sound deprivation. The second pillar, emotion, addresses the biological reality that chronic stress and fear dictate physical health outcomes. In the 11th century, the physician Avicenna illustrated this with 2 lambs. They were the same age and weight, but one was placed in a cage where it was forced to see a wolf. Despite receiving the same food, the lamb that lived in fear grew restless and died prematurely, while the lamb that could not see the wolf remained healthy. For a patient with hyperacusis, sound has become the wolf. Functional MRI data shows that sound becomes a constant threat that hijacks the brain's survival circuitry. When exposed to sound, patients show hyperactivation in non-auditory regions, including the spinal trigeminal nuclei, the thalamus, and the insular cortex. The amygdala is particularly involved, attaching intense fear memories to everyday sounds and keeping the brain in a state of high alert. This limbic hijack has severe clinical consequences. According to research, 13% of patients with tinnitus and hyperacusis report thoughts of suicide or self-harm due to their condition. To address the emotion pillar, clinicians work to regulate the autonomic nervous system, or ANS. The ANS controls involuntary bodily functions like heart rate and the stress response. Through targeted counseling and relaxation, clinicians can downregulate this chronic state of arousal. Auditory sound therapy cannot work if the amygdala continues to perceive noise as a life-threatening attack. The emotional response must be addressed to make the brain receptive to treatment. The cognition pillar focuses on the conscious behavioral reactions patients develop to survive in a world they perceive as dangerously loud. These reactions often create a maladaptive feedback loop. A sound triggers pain or fear, which leads the patient to engage in avoidance behaviors, such as wearing earplugs. This deprivation increases central gain, which in turn results in even greater sensitivity. Phobic beliefs about sound cement this cycle. By avoiding noise, the patient inadvertently reinforces the brain's false premise that all sound is harmful. The cognition intervention utilizes cognitive behavioral therapy, or CBT. CBT is a structured treatment used to identify and dismantle distressing thoughts regarding auditory environments. Through graded exposure to sounds and cognitive restructuring, CBT physically disrupts the avoidance loop. It replaces fear with controlled experience. Cognitive restructuring removes the behavioral barriers of avoidance, allowing the audiological desensitization of the central nervous system to take hold. The biological engine underlying both the development of hyperacusis and its cure is experience-dependent neuroplasticity. This is the process by which the central nervous system encodes new experiences and alters its function in response to training. Just as the brain learned to maladaptively rewire itself in response to acoustic deprivation, it can relearn normal processing. These graphics show neural networks becoming increasingly robust as the brain adapts to sustained stimulation. The SEC model unifies this healing process. Sound therapy provides mechanical recalibration, counseling calms the limbic system, and CBT ensures behavioral compliance for the brain to relearn. Clinicians must look past the outdated instinct to prescribe earclogs and avoidance for decreased sound tolerance. Hyperacusis is a manageable condition. Recovery is possible when treatment moves beyond the ear to address the entire central nervous system.